Today, we are discussing and sharing the surgery, RIRS surgery in horseshoe kidney. If you see here in the CT, it is the left moiety stone which is present in a non-dilated pelvis. It is approximately 1.3. You can see isthmus over the aorta and IVC, hard stone, HU units around 1200 units. If you see the cuts, 1, 2, 3, 4, 5 cuts afterwards, this is there. After that, 2 cuts are only there. That means in the lower part of the kidney. Usually, if it is in the lower part, it is difficult. Even if you see, it's not dilated system, and the colon is almost retrorenal colon. So for prone PCNL, you can puncture medially through the paraspinal region. RIRS is the best thing. So we are planning to demonstrate RIRS if possible with the fans access sheath. Now see, first what we are doing here is, I am already ready with the ureteroscope 6 by 7.5. First step in RIRS is putting the ureteroscope into the ureter. What is the aim is, see, ureter, if it is oval like this, we pass a guide wire. If this guide wire goes easily, better. Then ureteroscope 6 by 7.5. Here we are using wolf ureteroscope. This is the wolf ureteroscope. I am passing a thicker guide wire. Why? Because you can pass the access sheath easily. Now, once the guide wire goes in, obliquely we put the ureteroscope, enter, and then turn. This is the basic step of ureteroscopy. When I am seeing the ureter, it is dilated. That means today I can do the surgery very well. See the rugosities. See the rugosities. I am going up to the pelvis easily. That means today I can do RIRS. I wanted to do RIRS primarily with the normal sheath. What is normal sheath is, we use is Cook, any company is okay, 28 centimeter. This is Cook 28 centimeter over the thick guide wire. Carefully you have to pass, otherwise it may damage. So now I am passing into the kidney under the C-arm guidance. It is going easily. That means I can inspect the PCS. Now I am inspecting the flexible scope directly into the system. You can appreciate here, the flexible scope is going inside. Air bubbles have also gone. I am inspecting the PCS of the horseshoe kidney. You can see the edema here. So I could see the stone in the lower calyx, which is seen only part of it. Now I have to take call whether I can do. See, the moment I enter into PUJ, it is at the 6 o'clock position. It is very large stone in the isthmic as well as the inferior calyceal region. This is one of the ideal indication for RIRS. Now see, immediate dip is there. That causes lot of strain on the scope. It looks like calcium oxalate dihydrate on look. So if I can break the stone, I can take it out. But as of now, this is a big stone. So I am not planning for any basketing. Large stone, if you are not seeing all the stone, you should not do basketing. That is very, very important. So when I am doing, first thing is, I will pass a 200 micron laser fiber. I will inspect whether I can see the stone or not. With positive intent, I am putting the laser fiber and then doing the lasing. My settings are 1 joule, 10 hertz, total 10 watts. Even if I don't touch the stone, it will clear. Now slowly, I want to make powder only like this. See, I am not touching. Lot of people say that chromium is touching, thulium is non-touching. Not like that. Both can be touched, both can be kept at distance also. The powdering depends on your energy levels at the tip. If high energy level is kept, from distant only you can powder. If low energy levels are kept, you have to touch the stone. Now the problem in this case is you are not seeing the stone completely. So we wanted to do it slowly. Whatever the stone that is seen, first do it. Don't try to go here and there. Now I am seeing the 6 o'clock part of the stone. Very clearly powdering is happening. Very clear vision is there. Water outflow is good. And I am able to comfortably do even though it is deep inferior calyx. In this deep inferior calyx, I am doing the stone clearance completely. So see now below this level, I am not able to reach because PUJ is obstructing. So with deep flexion, I am able to do the stone. But I remind you, lot of the stone will be below. So we should not be happy at this level. We should be able to proceed with PCNL also if things go wrong. This is a deep inferior calyx where my flexion is extreme. But whatever the stone I am seeing, I am patiently doing it. Here I did not see I am pushing the stone, but still PUJ is obstructing my stone movements. At any cost, laser should not be fired at the PUJ region. Only on the stone we should fire. The distal aspect of the stone, see, I am trying to rotate the stone. It is not rotating. It is a large stone with a broad base. These are all required skill. Otherwise, you will lose the scope. In these cases, disposable scope is useful. I am using huge made scope in this case. No conflicts of interest. Biorad scope is also very good. Both are highly flexible. Both are durable. Both vision is same. So I am doing slowly with 1 and 10 joule, that is 10 watts. Whatever the places where I can reach the stone, I am doing it. The concern is whether I can do entire stone or not. Fortunately, uretropelvic junction is not high riding. It is straight going into the pelvis. So water outflow is good. Outflow is very nice. And there is no congestion. There is no bleeding because the water outflow is good. Now, layer by layer, I have done so far. Now I am facing problem. See, moment I reach inside, it is in the inferior calyx. I am trying to push the stone. If you push gently with the scope, it will not get damaged. So every time I am pushing 1 millimeter and trying to lift the stone so that stone will come in front of me. Here, the stone is not coming in front of me. I could not dare passing the basket. Now I am washing the whatever the dust that is formed in the, I am observing the outflow. See, this is the PUJ. The moment below the PUJ, stone is there. You should not try to cut the PUJ. It may stenose. So I don't want to do any cutting on the PUJ. Now what I have done, I increased my energy to 2 joules. Now I desperately want to break the stone like pneumatic lithotripter. I want to dig the stone. Still, stone is powdering only. So, very important point I wanted to tell is, when stone is very large, even if you increase energy, it will powder only. So, laser settings are not fixed. They vary depending on the volume of the stone, hardness of the stone, initial part of the stone. See, it is 2 joules. Still stone is not breaking. It is making hole, but not breaking. Why I want to make hole is, I want to weaken the stone. So here, I am weakened the stone and then I am continuously producing the stone pieces. Somehow, if I make PC, I am turning the stone with my laser fiber so that it is not turning. So that if the stone back is seen, I can finish fast, but I am not able to do. Still, I am not confident whether I will finish this stone or not. See, after making 2 joules, my laser fiber is burning badly. This is the dangerous part of high wattage. Now I am using 2 watts and 10 joules, that is 2 joules and 10 frequency. This 2 joules and 10 frequency is equal to 20 watts. So see how the 20 watts only is causing lot of sparks. These sparks I have never seen producing damage to the scope, but we should be careful. We should not go very nearer. See, still it is not breaking. So much amount of high energy I am using, it is not breaking. You have to wait. If the stone breaks into 2-3 pieces, I will be very happy because I can go to the fragmentation and popcorn mode. Actually speaking, the laser energy settings now are fragmentation mode, 2 watts, 2 joules, 10 hertz is equal to 20 watts. So I am not able to reach the bottom part of the stone because there is no space. Somehow, I am trying very hard in the isthmic region to produce the stone fragmentation so that fragments will give space. See how I am pushing the stone. These are the difficulties we have to address in a ectopic kidney, malrotated kidney, horseshoe kidney. You should have patience. Keep doing. Don't touch the UPJ. So now I am making whatever the method, I am trying to make fragments, but it is not becoming fragment because the volume of the stone is big. It cannot make pieces. Once the pieces are formed, it is easy for me to go to the bottom of the stone. Because bottom of the stone is not seen, I am having a problem. So we have to be patient. These stones are 1.5, 1.3 we think on CT, but volume is very high. In future, the stone size has no meaning. Only volumes are meaning. That's why we should have patience. Water outflow should be there. This is not a pre-stented case. This is not a pre-stented case. But ureter is very accommodable. I did not have any problem in passing the access sheath into the system. So when I do this, the stone is still becoming dust only. It is still not fragmenting even after the energy is increased because volume is more. When the stone become thin, the laser will break it into pieces. We have not reached that stage now. I am continuously trying to tilt the stone and get into space. It is not moving. This is called dependent trapped stone. So they are very difficult stones to do in RIRS. But this case is very difficult even in PCNL because it is in the isthmic region. The depth will be more. It is a slightly isthmic region will be anterior. And then puncturing the anterior calyx in prone, especially with colon, almost retrorenal colon, it is very difficult. Length of the tract will be more. So better to have patience in the RIRS. If possible, do half or near complete and then come back after some time. This is what exactly I wanted to convey, that I am showing extreme perseverance. See the air bubbles. Thulium fiber laser disadvantage is if you increase the wattage more than 1.5 watts, air bubbles will come. See, my laser fiber is not touching the floor. That is 12 o'clock, that is 6 o'clock position. So I am struggling to get, see, the UPJ is slipping. This is very dangerous. You should not use the laser fiber when it is slipping. So you should be cautious. Again, some part of the stone is seen. I'm lucky. So every 10% of the stone, if it is in front of the stone, it is very good. If it is not in the front, we will not be able to proceed. This is the powder as well as the small fragmentation. At the end, if the fragments are more, we can do popcorn or fragmentation. But at the moment, it is not happening. So I am trying to dig the stone and weaken it so that it will break into pieces. So now I am making drillings. These drillings, this is a completely unmodified video where we are showing a drilling into the stone. See, slowly I am reaching the bottom of the stone. In RIRS, secret is, if you see the lowermost part of the stone, inferior calyx, you can finish the case on that day. See, I am seeing lowermost part of the stone better. So now I am breaking it. If it breaks, I am continuously pressing the laser fiber into the substance of the stone. This cannot be done with holmium. But the advantage of holmium is 100 watts is, by this time stone might have broken into pieces. So the fragmentation capacity of a higher watt holmium laser is much better. But honestly, fragmentation capacity of 30 watts holmium will be equal to thulium. Whereas 100 watts holmium, if we had today, I might have broken this into pieces earlier. Thulium is making nice tunnel, but not really breaking the stone, because the thulium fiber laser lateral vibration is very less. So when the lateral vibrations, if you have the question asked by Krishnamurti is, how you are managing means my hand is flexing and pushing the stone into the as distal as possible. This is difficult. It is easy to answer the question, but in the maneuverability, you may damage the scope. You need little expertise. See, I am trying to see only the distal part which is accessible, but the bottom part is not at all able to push. Let me break as much as possible so that the stone gets floated. When stone gets floated, the chances of doing the surgery is very good. Now coming to the Sandeep Vadigari, air bubbles during RIRS while lasing, the biggest problem is this only. If you have suction, you can do suction of this thing. So air bubbles is the biggest problem in thulium fiber laser. Usually with washing, they will disappear. See, still bottom 20-30% of the stone is seen. Whether that stone will raise up or not, we have to see. If you increase the energy more, it is not useful because laser has to touch the stone. See, now it is becoming fragment. Had it been holmium laser 100 watts, it might have much. See, now it has become very thin, and the stone chances of migrating and then floating in the sea. Now it is broken. This is the what last success where you are 100% sure that this is thulium fiber laser. This is 2 joules and 10 hertz. I increased, initially I kept 1 joule and 10 hertz. Now it is 2 joules and 10 hertz. Now see, everything has become easy. All these stones are floating. I have not changed any setting. It is 2 joules and 10 only, but it is fragmenting. Previously it was powdering. That means there is no fixed laser settings. Same laser setting when the stone is big, it causes powder when the stone is big. Same laser setting when stone is broken, it causes pieces. This is nothing but pieces. This is one way of popcorn only. I have not increased the frequency. I have not changed the settings. It is 2 joules, 10 hertz, but still it is breaking. Last part, when the stones are very small, we will go to 100 hertz and 0.1 joules. That is called true popcorn. This is also popcorn, but this is in fragmentation mode. I say again, very important point. Laser settings are not fixed settings for powder, fixed settings for breaking, fragmentation, fixed settings for popcorn. No, it depends on which part of the stone, initial part or later part. See, now it is easily fragmenting. Previously, it was not at all fragmenting because it has a space. Air bubbles have space to break it. Whereas in holmium laser, in the beginning only, air bubbles will spread and break it. That means thulium fiber laser is focused. It is good for dusting, it is good for breaking after the stone becomes small. Whereas holmium is good for, in the beginning only, like pneumatic lithotripter, it will give big impact lateral spread, so that cracks will come more in holmium high watts, not 30 watts. So now this is the PUJ. Some stones have migrated into the other calyx. Some stones are here. At the end, this is the middle calyx. At the end, usually I don't inject contrast in the beginning. The reason is, if you inject contrast, efficiency of the laser fiber comes down. Water is better than contrast. Water, usually, if we are using in this case, at the end we will see whether we can use the fans. Now the trick is, I have used normal sheath, and then normal sheath I have used, and I am breaking. At the end, the ureter is dilated, then I will pass the access sheath and then suck all the fragments. That is the importance of this case. So anywhere, if you are doing fans in the beginning without stent, first to do normal with 9.5 by 11.5 access sheath, make as much as powder. After that, you insert the fans sheath. That I will show. So now I am doing powder. I am doing pop dusting. This is called pop dusting. Powder also will be there. Pieces also will be there. Same energy. So now I am changing to a popcorn. 0.1 joule, 100 hertz. See, it is very fast, but the pieces should be small. If the pieces are not small, popcorn will not affect. Popcorn means very low energy, high frequency. 0.1 joule, 100 hertz, total 10. All the pieces will come and hit the laser fiber by themselves, so that they will become small powder. You have to spend time. People can ask, why can't you do fans now? I want to wait for fans to be reinserted. As much as possible, I want to wait, because if you make powder and do fans, it is easy to suck. If you make fragments and use fans, it is difficult to take out all fragments. Many times 50 centimeter scope has to come out and come in. 50 centimeter scope has to come out and come in. So I will spend another 5 minutes here, make as much powder as possible, then insert the fan sheath. The advantage is ureter is dilated. You know the anatomy of the PUJ. You will not damage. You are using normal sheath below the PUJ. Then you will have a lot of advantage. Whenever dilated system is there, stones migrate. It's a big calyx. It will migrate, no problem. Maximum it will migrate to 1 or 2 calyx. You see, this is the calyx it migrated. Here also you do again popcorn. When fans is inserted, every calyx you will go and suck it off. So you have to spend some time in each calyx with fragmentation mode or popcorn. Now you cannot do dusting. So in difficult location, don't try to dust. I will say in 2 conditions. Number 1 is ureter, don't do dusting, try to fragment. Number 2 is in difficult location, try to fragment fast. That means in this case, I tried to fragment first 15 minutes, but it did not. Same settings, it powdered because stone was large. But when stone became thin, it made into pieces, and then we tried to make popcorn. See, now a lot of powder is there. This powder can be sucked easily with the fan sheath. But you can ask, why to use fan sheath? You can do powder only. But these small fragments, powdering takes a lot of time. These small fragments will be sucked by the fan sheath, by the side of the sheath, without removing the, see, so much powder is there. See, this is a big stone in the middle calyx. It migrated. So you should not miss any such calyx. You better inspect all calyxes. Now I am going into fragmentation mode, not popcorn mode, because this is a big piece. If you do popcorn, it will not lift the stone. Even if you increase the frequency, no use. You should have energy to break it. That means fragmentation, 2 joules, 10 hertz, or 1 joule, 10 hertz. With that, it will break into again pieces. Once the thing is, they become pieces and they become powder. After that, go to popcorn. See, it is still big stone. So I am breaking, and then I will make into small pieces. You should have patience. This is not a very patla. This is not very soft stone. It looked initially like calcium oxalate, but inside part is thick. So now 2 calyces I have gone. In those 2 calyces, I am making into completely fragment, small and powder. Here I will spend 15 minutes time so that fan's access sheath will not be there for a long time. So this is what exactly I mean to tell. So in the middle calyx, I am doing fragmentation and popcorn alternate to make the pieces so small that they can be sucked easily with the fan's action sheath. If you make bigger fragments and use basket, it will take 2-3 hours. Now approximately I have taken 20-25 minutes to come up to this stage. For insertion of access sheath fans, it will take another 5 minutes. After that, keep on sucking, everything will come out. Now everybody knows that 10 by 12 access sheath is coming. Now I am not doing anything, just spending time by doing popcorn method so that everything, if the vision is poor in RIRS, what you have to ensure is stop the first. Now if you stop, everything will be clear. Then come back into ureter. See that water is coming or not. Don't take out the flexible scope out of the system. Otherwise, redness will come. All the capillaries will bleed. The secret, it's a very good question asked by whom? Sandeep. The secret is without disturbing the water inflow and outflow, you have to do the surgery. See how small pieces have formed. I have not done anything. Just kept the laser fiber in the center, continuously doing, and total powder has come. Well, see, if you go distantly, very small powder. Now what I am doing, I will come out and I will take the new access sheath. In this new access sheath, see now I am inserting a thick guide wire, very thick guide wire. And I will put the access sheath of 50 centimeter length. This is from Aster company, Indian made. I don't know whether it is approved or not, but it is good. And it comes for 5 to 6 cases, very lengthy. Should be very careful. Slowly you have to insert into the system. Always under the C-arm. No question of inserting directly. C-arm, see at this level, slowly it goes into the PCS. It can perforate also PCS if you push. So you should know where the guide wire is coiling. You should stop there. See, here it is coiling. The tip can perforate the system like this. You should be careful. Now I am going with the same scope inside through the this. See, now I have gone into the system directly. It is in the pelvis. This is the advantage of access sheath. Now upper calyx I am seeing. This many calyces you cannot do in PCNL easily. This is a meaty kidney, retrorenal column, ideal case for RIRS. So RIRS has lot of advantage in these cases. See, I am sucking. I am injecting contrast to see the anatomy. Till now, I have not injected. Because where I am there, I want to see now. In the C-arm, if you see, it's a complex system. I did not know this much complex it is there. Usually, in PCNL and RIRS, head low, head up positions will not help much. Whatever we think, it will not happen because kidney is not that mobile. So I have not tried, but people say Lasix is useful. Alfuzosin or tamsulosin before given is very useful. That is okay. But if you raise full head and surgery becomes difficult. So I don't try any positions. See, now what is aim is to go to each calyx and inject the contrast and see where I am. Because now contrast can be sucked. Now suction can come. I want to see what are all the things in the. But the problem with suction is after that powdering is very difficult. So now see I am sucking. And the mucosa is coming inside. See my access. See mucosa is sucking into the lumen. It's dangerous. So PUJ you should not do that. So slowly I am going to each calyx. See, this is the powder. This is the powder I am sucking. You carefully watch. It's cleared. It's cleared. In 10 seconds, powder is sucked. That means if you do powder on this thing, as far as the ureter is concerned, I must tell you, don't dilate the ureter. If God has given a dilated ureter, you enjoy it. If God has not given dilated ureter, don't suck. See how I am sucking out entire thing. Not a drop is seen. Only this, see, I am going to the other calyx. Everything is sucked clean. It is like mopping with a towel. It is not like sweeping. See, inferior calyx I am going. Everything I am sucking out. Wherever the fragments are there, you have to withdraw. So now powder part is over. Now we have to see any fragments parts. As much as possible, bigger fragments, don't leave it. This is upper middle calyx. Now I am coming back. Can you see the clarity in the vision? So much it's sucked out. Every molecule is sucked out. So as far as the ureteric dilatation, if at all you are in hurry to do the surgery, I have a trick. You put 4 by, see now I am coming into inferior calyx, lot of powder and fragments are there. Now, how to put the flexible sheath into this? You cannot bend with the scope, it will break. You should go with the scope and thread it. Now the person is threading. The person is threading into that. So keep the flexible scope and then thread. See, is threading. And then come back and see where it has come. See, I am sucking all the powder part. So everything is sucked. So at the end, you will have a lot of satisfaction like in PCNL. See, these are the pieces. So I am sucking out. See, this is the laser burn. These are the deep inferior calyx. Deep, see, I am sucking out all the things. See, now I have to come out. If the large pieces are there, I have to come out nearly 50 centimeters outside and then go inside. You should be quick. And during this insertion, scope can damage at the time. So you should not bring out completely out. It should be at the Y junction. Don't come out of the Y junction. Otherwise, scope will bend. See how it is sucking. Suction usually is kept at one level. That is 10 mm of HG level, 100 mm of HG level. You should keep. In normal suction apparatus, we have connected. See, this is the small fragments. Go into the, see how I am guiding. How I am guiding the access sheet into the system. Now everything is sucked. In between, blood should not come. If any blood comes, it will get spoiled. Now, fans access sheet changing is not a great thing. Remove the normal access sheet after passing a thick guide wire and then fans. By that time, it is a big piece. Very dangerous. If it doesn't come out, what you have to do? Again, you have to insert. Now, water should be flushed, suction should be applied. Water should be flushed, suction should be applied. Water should be flushed, equal balance should be there. That means two important assistants are required here. One is person who is flushing and the other one is person who is aspirating the fragments. This is very important in this thing. Otherwise, if you do only suction, blood will come. If you do only water, pressure will rise. It should be balanced. Both should be different persons. Surgeon cannot do that. Surgeon can only manipulate the access sheath, can manipulate the flexible scope, but he cannot do both. This is a true fans mode of functioning. So now I am sucking out everything, one piece. So if you make more pieces, you have to do this exercise more often. If you do small powder and small fragments, you need not come out like this. So you have to balance between how much you have to do powder. If you do completely powder, there is no need to suck. If you big large fragments, you have to use basket. It takes a lot of time. It is frustrating. So maximum 10 to 15 times you can come out, not 100 to 200 times. So one should be very careful when you are analyzing this type of technique. New technique it is. It is still in the world. Not many people are using. So you should be careful. Don't push back and front by the assistant. The assistant will hold the sheath in position, but they should not push. The tip is very sharp. It will damage the calyx. It will damage the UPG. It will damage the mucosa. That can cause stricture and perforation. They should keep in still position. You should constantly observe. The senior sister must assist. Because the operator is not there, access sheath can perforate anything if they push to help you. No, they should not withdraw also. If they withdraw, you cannot go to the same calyx. See, every time I am coming, exactly same calyx I am going. That is because of the technician. So one technician will flush with water 200 ml syringe or pump or low phase pump. Previously, we never used to do pump. Now again pump is coming. Why? Because pump constantly will be telling. A technician may not flush. Whereas the pump will see how the mucosa is sick, how much powerful is mucosa. Still one drop of blood is not seen because flushing person is very active. Here, Mr. Sridhar is flushing and sister is closing. So these things you need. Sridhar is 17 years technician. So when you are doing This much fast, smooth may not happen. Don't worry, go slow and don't misbalance the inflow as well outflow. Now, I wanted to inspect the isthmus in this case. After finishing, whether I can go to isthmus, what is there in the isthmus, I want to see. 99% of the stone is over in 32 minutes of time. Approximately, it is 32 minutes of time. So what I wanted to know is, now what are all these stones? See, almost nothing is there in the kidney. Almost nothing except this fragment. Sometimes they don't come out. You have to struggle. You have to go and hit. And they will be floating. They will go to one calyx to other calyx. This is nuisance for everybody. But these are very small. They will come out. You should not bang your head for continuously spending and making edematous the kidney. You should not do that. So what I personally feel is we should completely suck the fragments. So repeatedly go spend some time. See, these are small fragments came out. They cannot be flushed easily. Bigger fragments can be flushed. Can you see some damage of the sheath every time you are going in and done? Black dots will come. That will damage the inner lining. This is a smooth plastic cover like thing. So this case, every case, it gets damaged. See, I'm repeatedly enjoying seeing. You can see erythematous small patches in the mucosa. That is because of the forcible flushing or because of the stent. One must avoid. See, completely collapsed. Completely collapsed, and total system is if you want to direct the access sheet into different calyces, under Siam you can do it. I will show. Under Siam you can see this is the access sheet. Now I am pushing slowly into the inferior calyx under Siam. At the same time, I wanted to go to most deepest calyces so that I can see any stone is there or not. So now my job is to inject contrast. Go cyst, see, completely cleared. Complete. Repeatedly I am washing. This patient, fever will not come because intrarenal pressure will be less, and stones will not be there because you have sucked so much. So definitely patient will do. See how I am guiding the sheath along with the scope. See, now some more amount of powder again has gone into the different calyces. So you don't have choice. You should have patience. See, this powder is sucking without scope being removed by the side of the scope and sheath. What is the scope size? 7.5. What is the sheath size? 11. So what is the difference? 3.5. In this 3.5, what amount of suction can be done? 200 micron dust. This is 200 micron dust. That's why it is sucking out between the scope and the sheath. So there is no problem. So you can continuously suck that. You can continuously suck that. So these are the important thing we wanted to observe in the RIRS surgery. So small powder can be sucked between the sheath and the flexible scope, whereas large fragments you have to remove entire flexible scope 50 centimeter out. See, after washing so much time also, some amount of this thing. Because this is endo view, I am not able to frequently switch over to the Siam view. I am sorry for that because we don't have double switch over. That's why I am showing this. Definitely, I will show endo the Siam view once I completely clear. Because for that external view switch over, I have to remove this and go for that. Picture in picture is not available with. I have to buy that. It will cost around 5 lakhs. So I will buy, and then at that time you can do picture in picture both. That's why I am doing only endo view now. See, endo view is completely there. If you have switch over, they are all costly items like Panasonic, Sony companies will produce. If you have switch over, then you can keep both in picture. If you don't have switch over, I have to remove this wire and put it. Again, transmission may get interrupted. So I am going in and out. I am going in and out. Every small molecule I am washing out. So the kidney will be very happy when you remove all these stones, dust, clot. See, I am removing clot 1, 2, and 3, I push and suck, I push and suck. So clots also can be removed. It is very difficult to remove the clots with laser because water will not be absorbed with the clot. It is very difficult to do basketing of the clot. See, these are the last few fragments. Even in PCNL, they will be there. But in RIRS, if you continuously do suction, they will disappear. I will ensure that in this case, everything will disappear. Tomorrow, if I do CT, there is very less chance that big stone is seen. Then patient will have a lot of satisfaction and stone will not get impacted in the ureter. So every small fragment, this thing. In future, if the small scope comes, 6 French is released in Dubai, it seems, then you will really enjoy it. But access sheet size also should decrease to 8 French. So if 6 French small scope and 8 French access sheet is present, you can do wonders. You can do wonders because stent roll will decrease. Primary RIRS will increase, but definitely it will happen. What is the big deal in getting 8 French fans sheath? They will get it. Companies will make it. Everywhere miniaturization is happening. Exactly, I tell 1 GB has come in a truck 30 years back. Now 45 GB is coming in pen drive. See, again I am going into the middle calyx. Again I am sucking out. I am spending time purposefully. Normally we leave at this stage. All the RIRS surgeons, we will leave at this stage thinking that everything will fall. Correct, they will fall also. But if you wanted to be perfectionist, you suck it off everything. Yeah, suck it off. See, now 99% I have finished. All these stones in all calyxes I am sucking out. If you take the access sheath into mouth of the calyx, they will be better. See, now I am taking the mouth. Now access sheath I am taking into the mouth of this calyx. See. Directly into the mouth so that they cannot escape. They have to come out. These are all very, very difficult maneuvers. What the trick I wanted to tell is, put the flexible scope in the desired calyx and thread. Don't bend. It won't bend easily. If you thread under Siam, it will thread nicely. Very clear vision will be there at the end. I don't want to inject contrast in the beginning. That's why you are not appreciating. Otherwise, it is very difficult case. Honestly, I'm telling. These are all middle calyces. If you go deep only, the inferior. See, if you go still deep, see these upper calyx, middle calyx, and if you come back, then it will happen. Now I wanted to see isthmus. Whether you can go to isthmus or not is my interest. That is very difficult because isthmus is anterior. Isthmic region, if you want to reach, supine PCNL is best. If the supine PCNL is there, it is better. So one should be very careful in going to abnormal regions without RGP. See, now I am injecting contrast. All the calyces I am injecting. I am confident that even if I come out, nothing will happen. Can you see the contrast clearly? Is the Siam available? So we will show the Siam also. Try to prepare. At the end, at least I wanted to show the Siam, all the pictures. At the moment, we are not able to detach. I am trying to go to isthmus. Please bear with us. Next time, we will definitely bring both Siam picture and this. See, I am searching in the region of isthmus with the Siam help. Sorry to say, I am using the Siam now because I don't know where is isthmus. I am coming medially onto the spine. So that is the most important thing. I will show that. Once I am into the isthmic region, whether I can reach that extremely medial. This can damage the scope. But if you use Siam, you will be careful where to go. So that's why in the beginning part of RIRS surgery, always have RGP and guide RGP. But the problem with RGP is if you flush very hard, entire kidney become see, I am going down. This is all Siam guided. I am struggling to reach the isthmus. It is very deep. I am flexing very much. See, mucosa abutting and flexing. See how much I am flexing in my hand. I can only know. Scope can get damaged. I am not able to find the opening of the isthmus. I will try. So if you go and if you can reach the, see, this is the new calyx. This is the new calyx. This is the new calyx. See, some fragments are here. This is the ischemic region. This is not the previous calyx. It is directing towards the 9 o'clock position of the scope, 9 o'clock position. This is a different calyx. I will inject the contrast at the end. I will definitely show. This is the isthmus. Can you see the isthmus? Deep, deep isthmus. See, now I am passing the stent because I have finished. Now I will inject the contrast and show after the at the end films. See, this is the picture. Now we have disconnected. This is the ischemic region. I have gone. See how much complicated anatomy it is there now. This was the picture because we could not show simultaneously. At the end, I have shown this. This is the area where small powder is there, but that powder will come out. So most inferior part, the stone was there on the 3 o'clock position, and I could enter the isthmus and could show clearly. If you thread the sheath over the scope, yes, chances can be there because there will be gap. But the secret is don't push directly, rotate, slowly, slowly rotate so that the sheath will touch this side, that side, this side, that side, this side, that side, and then enter. But generally, in the ureter, it can happen. In the pelvis, it will not happen. This is the last picture of RGP with collapsed. If I have injected first picture RGP, you might have appreciated. Next time, we will show both picture in picture as well as this. In this case, we could not show at the end. Now I have put the stent. The surgery is over. To conclude, the number one point is, in ectopic kidneys, Horshoe kidney, first ureteroscopy. Number two, don't do RGP aggressively. Number three is pass a guide wire and use normal access sheath 9.5 by 11.5. Do RIRS normally like any other case. Try to make fragments as early as possible if difficult location. Try to do popcorn if the pieces become small. Try to make as much as powder possible. Small fragments at the end, if you want to remove, you exchange with access sheath. In the access sheath, you pass a thick guide wire under C-arm. Remove the access sheath. Pass 10 by 12 flexible access sheath. Then thread up to pelvis. Then with the suction as well as water flow or the pump, you can go inside. Go to each calyx and keep on sucking with water flow. All the powder will be sucked without removing the scope. After the fragments are sucked, the scope has to be withdrawn. This maneuver has to be done 10 to 20 times. After that, repeatedly inspect all calyces and suck out the powder. The powder will go from here and there. Abnormal calyces we can go through the RGP guide like this. Into that also you can pass the access sheath, but be careful because very abnormal location it may not go, but most of the times flexible access sheath by this Aster company is going to my experience. At the end, inspect the ureter and come out. I have put directly stent, don't do that. Directly inspect and then put stent. Preferably put large stent. Previously, I used to put 3 French, better to put 5 French in primary case. If the RGP is normal, if the stent is placed, 99% patient will not have problem. If any fever comes, convert into piperacillin tazobactam. Otherwise, I am using ceftriaxone sulbactam. I am not using amikacin. High grade fever comes, I will change to piperacillin tazobactam. After 1 day of piperacillin tazobactam, if high grade fever comes, I will go to meropenem. Sometimes I will give hydrocortisone 50 mg TID first day if patient does not have urine culture positive. If patient is not diabetic, I will give hydrocortisone, especially youngsters. This reduces the systemic inflammatory reaction, but you should be covering with the antibiotic first. So usually 1 day we will discharge the patient. Stent removal after 12 days. I am enjoying this fans sheath recently because of the high stone free rate. These type of ectopic or mal-rotated or Horshoe kidneys will have high recurrence rate. Metabolic workup is mandatory. With this, we conclude the session. Thank you once again for watching the video. Pre-stenting can be done in all the cases, but in this case, I attempted without stenting. I succeeded. But if the fans access sheath is not passed, I will stop. I will do relook. I will do relook. But in this patient, he is lucky. Patient has dilated ureter, patient has normal sheath gone, patient has access sheath of bigger gone, patient has suction gone, patient has isthmus region inspected. I will share the CT after 2 weeks stent removal in the social media. You can appreciate how much clearance will be there. Anybody who is doing fan sheath can appreciate high stone free rate. We can reach up to 100% stone free rate also with the access sheath. That is the point for pre-stenting. I think we can conclude the session. Thank you very much for watching.